keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
G'day and welcome to this edition of JACC Imaging. My name's Tom Marwick, one of the associate editors at JACC Imaging, and I'm here with Mary Hooley from UC San Francisco and the VA Medical Center in San Francisco. And we're going to talk about Mary's work on the transthoracic echo heart failure index, index for predicting the development of heart failure. Mary, congratulations on your paper.
Thank you.
I wonder if we could start off with briefly summarizing what you found.
Absolutely. There are, as you know, a number of echocardiographic variables that predict cardiovascular outcomes in patients with stable heart disease. And we were interested in whether combining all of them together might be able to create a stronger risk index than just looking at each one together. So we evaluated 15 different echocardiographic variables, and we saw which ones most strongly predicted heart failure. And then we combined those 5 variables into an index that has resulted in this TTE heart failure index that did very strongly predict heart failure.
I think the principles behind that are great, aren't they? We're used to using indices like this in, for example, the Framingham score, so to apply it to echo is really nice. One of the issues that you might have about using echo for this purpose is its transportability among different labs and the ability to reproduce exactly the same measurements. What were your thoughts about this, and what aspects of this do you think could be problematic?
Well, I think that's really an excellent point, and any derived index like this has to be validated in other samples before it can really be used in clinical practice. And there were several issues that would make it particularly set for our sample. One is that we had one echocardiographer, Dr. Nelson Schiller, doing all of the readings, and 2 is that it was in our one, we had one echo tech doing all of the measurements, and 3 is we have one patient population, and so we had patients with stable coronary disease. It may be that this particular index is not going to work in patients in the general population or in patients after acute coronary syndrome or other groups of patients. I will say that in our study population, we did have patients from 2 VAs, 1 university medical center, and 9 public health clinics in the San Francisco Bay Area. So it was a general population in which we derived it, but you're absolutely correct that it needs to be validated in other samples before it can be used in routine care.
Okay. One of the other aspects of the index that I found particularly interesting is that there's a score for particular items, such as left atrial enlargement or mitral regurgitation. Did you think about having different levels of scoring for each of those items, and would that have made any difference?
That's a great question. When deriving an index, there are several ways to do that, and you can look at all the different potential cut points of left atrium and pick the one that best differentiates between bad and good, or you can look at 3 different left atrial categories, left atrial size, low, medium, high, and differentiate which one predicts heart failure. We decided to choose one cut point a priori for 2 reasons. The first reason is that, again, for because of the first question you brought up, we didn't want to overfit the TTE heart failure index to our particular sample. And so if we had just derived whatever the exact cut point was that predicted heart failure in our sample, it would have been less generalizable to other patient populations. So we decided a priori that we wanted to choose these standard cut points to use for the index, and that way, even if they weren't exactly perfect for our patient population, they would be more generalizable. The other issue just comes down to ease of use and having something that's easy for people to remember. It gets, the more bells and whistles you put onto an index, the harder it is for people to remember, and then the less likely it is to get incorporated in clinical practice. So we wanted to have something that would be easy to remember, quick, and simple to use.
Okay, that's great. Well, I think this is a very attractive development. It will take us on from where we are currently with single parameters, and I think the validation in other centers will be interesting. Thank you so much for joining us at the JACC Imaging.
Have
a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.